Dr. Afzali, you are a thought leader in the world of inflammatory bowel disease. Your focus is on advanced therapeutics in inflammatory bowel disease for adults. I would like to ask your opinion about some recent updates in the world of IBD. In the past, we have typically had one class of biologic therapy, the anti-TNF therapies. But now, and in the near future, we will have at least 3 different mechanisms of action with regards to the different biologic therapies that we will have. Are there specific patients that you think would benefit from an alternative mechanism of action aside from anti-TNF therapy?
First of all, we need to make sure we highlight the importance of having now other options of treatments outside of the one class of prior biologic treatments that we had, so the anti-TNFs. The IBD pipeline, drug pipeline, it's exciting to have different mechanisms of action, or MOA, and to be able to offer different MOAs for our patients, particularly if they are unable to respond to our anti-TNFs, is very beneficial. We know that about 30% of patients are primary non-responders to anti-TNF agents. So to be able to offer a different MOA for these patients will be very helpful for the management and treatment of their disease. We also know that inflammatory bowel disease is a very complicated disease process. There's not just one mechanism of action that works. In other words, the inflammatory cascade and the pathways is so diverse that we absolutely need different MOAs for the treatment of IBD patients.
And are there certain groups where you see the choice for some of these new modalities be the top choice before you use an anti-TNF agent?
Absolutely. I mean, we know that certain patients, for one reason or another, there's a contraindication for even starting an anti-TNF agent. For example, severe congestive heart failure, multiple sclerosis, high risk for tuberculosis or prior tuberculosis. These are patients that we would actually consider a different MOA, and sometimes even the safety profile of these other MOAs is more appealing for consideration of starting as a first-line agent.
And what is your take on where the safety profile for these new agents is compared to what we are used to historically for treating IBD?
I mean, we need to first be aware that we're learning more in regards to each of these different therapies. Some of these agents now becoming FDA approved for the management of IBD do not come with a black box warning, but this may develop over time. But the safety profile of these therapies, it depends on the MOA. Certain gut-specific agents may be just that, gut-specific, with lower risk for infections, for example. But other therapies, their risk for adverse events or the safety profile may be similar. And so we're going to learn more about these new MOAs and the newer therapies in the management of our patients.